Persistent genital arousal disorder (PGAD). What is it? Persistent genital arousal disorder or PGAD is characterized by unrelenting, spontaneous and uncontainable genital arousal, mostly in females. A woman with PGAD can experience spontaneous orgasms that do not resolve arousal. The person's arousal is not linked to sexual desire. PGAD can lead to ongoing physical pain, stress, and psychological difficulties due to an inability to carry out everyday tasks. The condition can affect women of all ages. Experts have not clinically confirmed the incidence of PGAD, as many people with the condition feel too embarrassed or ashamed to seek medical help. Symptoms. The primary symptom of PGAD is a series of ongoing and uncomfortable sensations in and around the genital tissues, including the clitoris, labia, vagina, perineum, and anus. The sensations experienced are known as dysesthesias. They can include wetness, itching, pressure, burning, pounding, pins and needles. This can lead the person with PGAD to feel consistently like they are about to experience orgasm, or they may experience waves of spontaneous orgasms. However, these symptoms happen in the absence of sexual desire. Climaxing may temporarily alleviate symptoms, but they may return suddenly within a few hours. Episodes of intense arousal may occur several times a day for weeks, months, or even years. The condition can lead to psychological symptoms due to the persistent discomfort and impact on day-to-day living. This may include anxiety, panic attacks, depression, distress, frustration, guilt, insomnia. People with chronic or incurable persistent genital arousal disorder may eventually lose their notion of sexual pleasure because the orgasm becomes associated with relief from pain rather than an enjoyable experience. Priapism, PSAS, and PGAD. What is the difference? Some doctors class priapism in men as a type of persistent genital arousal disorder. Priapism is a persistent and unrelenting penile erection without sexual desire. PGAD is not associated with hypersexuality or an elevated need for sexual gratification, otherwise known as satyriasis in males or nymphomania in females. The condition was formerly known as persistent sexual arousal syndrome or PSAS, but the name was changed to PGAD as PSAS suggests active sexual desire. Causes. Sexual stimulation, masturbation, anxiety and stress can trigger PGAD. Some people find that going to the toilet results in such severe arousal as to be painful. However, the person with PGAD cannot usually identify the triggers to avoid them, and the causes of the ongoing condition are largely unknown. In some women, stress causes the onset of the disorder. Once the stress is alleviated, the condition tends to calm. Some therefore think that PGAD may be psychological in nature. However, this is not the case in every presentation of PGAD. Research has implied a link between PGAD and the veins, hormones, nervous systems, and chemical balance after using some types of medication. Research has shown that Tarlov cysts may also cause the condition. Tarlov cysts are sacs filled with spinal fluid that appear on the sacral nerve root Sacral nerves at the bottom of the spine receive electrical signals from the brain, and they relay these instructions to the bladder, colon, and genitals. In a 2012 study, MRI results showed that 66.7% of women who demonstrated PGAD symptoms also have a Turlough cyst. This does not account of every case, but in some cases PGAD may be considered a reaction to a Turlough cyst. Paresthesia refers to a burning, itching, tingling or crawling sensation. Researchers have also demonstrated PGAD as a secondary symptom of Tourette's syndrome, trauma to the central nervous system or CNS, epilepsy, post-surgical effects of intervention for malformed veins or in the lower back. Studies have also investigated whether PGAD is caused by changes in hormones or medications. However, in many cases the cause is unknown. This creates difficulty in diagnosing and treating the disorder. Treatment. The treatment of PGAD usually centers on managing symptoms due to the often unclear causes of the condition. Psychological treatments such as cognitive behavioral therapy or CBT can help women identify their triggers and can also provide some coping mechanisms and distraction techniques to manage the physical symptoms of the PGAD. CBT can also help in managing the stress, anxiety, and depression that often accompany and worsen this condition. In severe cases, electroconvulsive therapy or ECT has also been shown to make a positive impact. A person with PGAD may physically manage the pain and discomfort by applying ice to the pelvic area or taking an ice bath. A variety of topical pain-killing agents is also available. Topical applications can be applied to the skin to help the relief of symptoms. In ECT, small electrical charges are passed through the brain of a sedated patient. This triggers rapid changes in brain chemistry to treat a psychological symptom. Prescribed medication or changes in medication can help to manage the condition. Changing current medications by removing drugs with herbal estrogen or known aggravators of PGAD has been shown to improve symptoms. Antidepressants and anti-seizure medications have been demonstrated as particularly effective, as well as medicines that increase the level of prolactin or milk stimulating hormone in the blood. In nerve-related cases such as a Turlough cyst, the treating doctor may suggest surgery such as releasing the nerve from entrapment.